For more than 47 years, our nonprofit, Resources for Seniors, has supported older adults and caregivers in Wake County. We can help in many different ways, including adult daycare programs, ramps and repairs, in-home supports, and consultation and referrals. Indeed, we're who to call when you're not sure who to call. Resources for Seniors stands ready to support you in your caregiving journey.
I'm Mark Costley, the founding attorney of Clarity Legal Group, the Triangle Area estate planning and elder law firm. You know those people who become overwhelmed dealing with the multiple challenges of being a caregiver? Clarity Legal Group helps people establish legal tools that avoid confusion, give them peace of mind, give them asset protection, and in some cases help them qualify for Medicaid. We help people get it right in the face of some of life's most important challenges. We don't just provide wills, trusts, and powers of attorney. We provide solutions and ongoing support. We provide clarity and peace of mind. It would be a privilege to help you.
Are you like 80% of seniors who would like to age in your current home? Call Wisdom Senior Care. Are you currently taking care of a loved one and finding yourself frustrated, tired, and even lonely? Call Wisdom Senior Care. Always available, dependable, and flexible. Come partner with Wisdom Senior Care, keeping wisdom at home.
My name is Cooper Linton, co-host of Edge of Aging, a platform that was created a few years ago to act as a home for innovative and creative ideas in healthcare and elder care. I also operate Duke Home Care, Duke Hospice, and Duke Home Infusion for the Duke University Health System.
And I'm Nicole Claggett, also a co-host of the Edge of Aging program, and I am also the executive director and co-founder of Transitions Guiding Lights Caregiver Support Center.
And absolutely none of that matters, because we're going to be the curators of other people's stories today, not your speakers. So Nicole and I would like to invite you on a Spark Talk today. What's a Spark Talk and why does that matter? Well, it's very simple. SPRX, service, purpose, resilience, and experience. We know experience starts with an E, but it just wasn't cool. So SPRX, Spark Talk, the concept is actually pretty straightforward. If you think about your service as a person, it should align, or at the very least intersect, with your purpose. And how do we fuel that? Well, that's our resilience. That's how do we keep our service and our purpose fueled and moving forward. And then experience is, well, if we really have lined up our service and our purpose and we fueled that, shouldn't we be compelled to create an experience for ourselves, for our teammates and our colleagues in our workplace, and ultimately for our patients and their loved ones? So today, we would like for you to join us on this Sparks journey as we follow three people, each with their own voice, each with their own perspective, one of a patient, a caregiver, and the one who's left behind and rebuilds life, the bereaved. Joining us in just a few moments will be three guests who are all well known, but they're really not here in their professional capacity at all. So we'll start with, in no particular order, Stan Massey, who is the lead consultant for Transcend Strategy Group. Stan and his colleagues have done more hospice and patient family experience surveys and interviews than really almost anyone else in the industry, 18,000 of these. And in fact, the National Hospice and Palliative Care Organization asked them to lead the Moments of Life campaign a few years ago. But today, Stan isn't the lead consultant. Stan is the surviving husband who took care of Paula as she fought lymphoma, as he was a caregiver, as he began to rebuild life after her death. We will also be joined by retired Brigadier General Steve Smith, who is also retired as the first Chief Human Resource Officer for Duke University Health System. Today, he will be sharing the story that Lucy, his wife, has agreed to share with us as well, of their journey as a married couple, where he is a caregiver and she was a caregiver, and talk about how that has formed their life and their marriage and he will introduce us to his concept of perks. I think you're going to enjoy that part. Our third stop, if you will, on today's journey will be Tiffany Christensen, the Vice President for the Barrel Institute. Today, Tiffany, though, is speaking from the voice of the patient. Specifically, the voice you will hear today is from her third set of lungs in this life, and she's currently facing kidney failure. She will give voice to the perspective of the person that we treat. It is our hope that these narratives, these stories today, will resonate with you. In fact, you may even identify with them. But we will ask that you listen to them within the framework of your own service, purpose, resilience, and experience. So enough of my talk. Let's get started on this journey, and thank you for joining us.
Lucy and I were high school sweethearts. At least I was really stuck on her. And then we went off to college, and after college we got married. We're planning to do a number of different things in academia because I was studying zoology. But the Army came along and said they had different plans, and we got drafted. I got drafted. So we went into the Army thinking that this was the worst thing that could possibly happen, this major interruption in our life. And so we ended up staying 28 years almost 28 years in the Army. During that time, Lucy gave her life for my career. I moved the family 18 times in 27 years. Wow. 2 kids. In the later years, Lucy's mother joined us. And I'll give a little background on that story too. But all the moving, and throughout all that, Lucy taught me a lot of things. She taught me how to care for our children, even though the Army was a very, very demanding career. She taught me how to cope, how to adjust, how to have a sense of humor, how to have a sense of perspective. She did say that move was a 4-letter word. So that's a little bit of background. Going in terms of the caregiving, her dad was gravely ill, lived in Michigan. At the time, we probably had 20 years in the Army. And we were stationed at Washington, in Washington State at Fort Lewis. And so we were visiting her mother, and her dad lived, and they were living with her stepbrother, Lucy's stepbrother. And I was sitting with her dad. He was a paraplegic, and he was in bed, and he said, I said, "Dad, how are you doing?" We used to just hold hands. We'd just talk. And he squeezed my hand and he said, I'm afraid to die because I don't know what's going to happen to Mary. Mary is his wife, Lucy's mother. Mm. Well, without consulting Lucy or thinking through this, I said, "Oh, Dad, don't worry. We'll take care of Mary. She'll move in with us." Well, she had senile dementia, and that's why he was particularly worried about what would happen to her. He looked at me and he said, "I'm at peace. I'm fine. And thank you. I love you."
It sounds like you've been caring for your whole life. Talk to me about how you found yourself caring for Lucy.
I retired in January of 2016. In February of 2016, Lucy was making the bed, and I heard her sit down, and I heard her gasping. And I went in and I said, "Are you okay?" And she said, "I can't breathe." So we got her to our primary care doctor, and I was waiting outside, and while he was looking at her, he called me in. He said her oxygen level is below 80%, and it's not improving. So we got her over to Duke. She was in the hospital 9 days with a blood clot in her right lung and pneumonia in both lungs. I remember talking to her pulmonary doctor, and he said, "Steve, this is very serious. It's pulmonary fibrosis." There is no cure. We don't know exactly why it occurs. We can medicate. We can try to alleviate some of the symptoms. But at some point, you may have to think about a lung transplant. So those plans we had to retire, and it took a little bit of strength on my part not to feel guilty for moving them around 27 years, or 18 times in 27 years, and not retiring when I should have, to allow time that we had. On the other hand, we did a lot of traveling. We lived in Europe. We did a lot of different things. And so neither of us got into that, oh, woe is us. And I remember talking to a very good friend, and he said, oh, this just seems so unfair that this should happen before you really had a chance to enjoy retirement. And I said, no, we're not going to go there. This is not unfair. We're in our 70s. We've been married almost 53 years, 2 wonderful kids, 3 wonderful grandkids. That's a very fair life, as it is right now. Sandy Hook was not fair.
Right.
But having to adjust your life because one of your loved ones needs you, that's fine. And so I realized that I was going to go into my 3rd career, Army officer, HR officer, and now candy striper. It was about a month into the caregiving, and I never felt it was a burden at all. It was an adjustment, but it wasn't a burden. And I'd helped her shower, and she got out of the shower, and she wouldn't look at me, and I kind of leaned over, and she had tears just streaming down her cheek. And I said, what's the matter? And she said, I'm such a pain in the ass. And I took her face in my hands and I said, you are not my pain, you're my purpose. And that seemed to be kind of a, let's move on, Lucy. You know, don't you start feeling sorry. I'm not going to feel sorry. We're just going to be the best we can here. I think that if you don't get hooked into things like, this isn't fair, or why did this have to happen? You maintain the sense of perspective. You maintain the sense of humor. It could be. We might be able to have more fun if this hadn't have all happened, and yet I really waxed her at cribbage yesterday. So.
I'm struck by your calmness with all of this.
What I don't want to paint a picture of I recommend caregiving for everybody.
This too could be for you.
Yeah, but because it does raise my anxiety. Is she okay? She had a coughing spell last night about 3 a.m, and I just, you clench up. But you got to reach a balance. How much of that anxiety are you going to share with her? Because I try very, very hard not to have any reason for her to worry, if I can help it at all. But I do worry about, we don't have a master bedroom on the ground floor. We're going to have to deal with those kinds of things here before too long. And I've got 2 friends, they've all downsized. Come on, Steve, get with it. Well, I don't want to put Lucy through that kind of stuff.
If you could introduce us into the topic of perks.
I was sitting in Lucy's room. She was completely asleep. And I thought, I need something to follow here. And suddenly the word perk came up. And I just sat there and I thought, patience, empathy, respect, and kindness. Perk. Well, that makes sense. And then I added one later, selflessness. And what I found was that of those 5 things, probably the most difficult one, the most challenging one, is patience. And I really remembered that with Mary, because I did lose patience. The kids tell me, no, Dad, you were a great example. Well, not the example I could have been. Empathy, and there's no way that I can really understand what she's going through. There have been times in my life where I couldn't breathe, especially when I tried swimming and breathing when you're trying to swim. But so the best you can do is combine patience and respect and have a little empathy. That's the best you can sometimes do in terms of really understanding what they're going through. But selflessness, that's not hard in a 53-year good marriage to say, I'm secondary here, that this is what matters. So you tell us, yeah.
What's been your hardest moment in all of this, Steve?
The hardest moment was when they put her in the hospital and I saw her suffering greatly. And they had tubes and, because she had just crashed. And while my faith tells me that these things are part of life, and as is death, I still, because of the strength that she's given me over these years, I really don't know what I would do without her. And so I have this, it's sort of a theological or emotional contradiction, about things, but that's been the hardest.
What has been your greatest gift?
Seeing somebody like Lucy be brave and optimistic and drawing strength from that. I either ride my bike or walk or every day, and a day doesn't go by that I don't, as I enjoy that bike ride, that I just think I am so fortunate to be with her. And as long as she is reasonably comfortable, reasonably safe, this is just a fantastic opportunity in my life to have some perspective about somebody else.
What can we do as leaders running organizations, working with some of the direct care staff that are working directly with the family caregivers and patients? What can we do to help really fuel those individuals from not being burned out and from being able to come into their jobs every day practicing perks? Because a lot of people are just checking out of this industry because they can't give anymore.
Yeah.
And something's missing. What's missing, and what can we do?
Well, I don't want to get overly dramatic on this, but what's missing is in healthcare, is missing in our Congress, is missing in a lot of our churches, is missing in the way we treat people in law enforcement and our schools. Our nation is suffering with some very, very bad habits right now. And what is missing in our Congress and in healthcare particularly is collaboration, cooperation, coordination, I guess. People are at their worst when they're greedy, when they're selfish, when they don't work together. The thing that I think I mentioned it, but what I appreciate so much, people understand who's giving the care and why is the care. And if you do that, there's a major outcome of that. If you're the caregiver, you don't feel alone. You feel supported. You feel backed up. You feel inclusive. You feel relevant. And that's where really, really good leaders can make a difference. Whether it's a nurse manager. And when I gave a farewell speech to our nurses, and I said, I just want to be remembered for one thing. my name should be linked to appreciation for our nurse managers and our other managers, but particularly our nurse managers. A good nurse manager, oh my gosh, they work wonders. They work wonders, up and down and sideways, and they'll grab a doctor by the nostril and tell him to knock that stuff off. And yeah. I don't want to make myself out as having figured all this out. I really don't. I get anxious. I worry about Lucy. I'm careful not to dump those emotions on her. So I need friends and have friends who help, me work through these kind of things. Our kids help a lot. So I don't have it all figured out. And I know that there are caregivers who are faced with far, far deeper challenges and pain and suffering that Lucy and I are not going through right now. So just take what you heard with a grain of salt.
Stan, thank you for joining us. We appreciate this.
It's my pleasure.
So I thought we would jump in not with a question about what you do for a living, but can you take us back to the story that a lot of folks don't know about you, which is life with you and Paula, and how you became a caregiver and where it goes from there?
Paula was a very vibrant and vivacious lover of life. In 2007, she had a backache and it wouldn't go away, so she asked me to take her to the ER. I was literally on my way out the door to go to work. And we went to the ER thinking it was some muscle pull or something. It turns out that she had non-Hodgkin's B-cell lymphoma that pretty much congregated in her back first and then spread throughout her body. She got a very successful round of chemo, and it went into remission for about 4 years. And during that time, we lived life to the fullest. We had an RV, we went out west a lot, loved going to the Rockies, and just really had a great time. When the lymphoma returned, it returned with a vengeance. And this was around 2011. So all of the treatments, including the chemo regimen that she had the first time, were unsuccessful. And no matter what the doctors tried, she was just not improving at all. So the last 2 years of her life were a steady decline, and she ended up really needing very intensive care. And because of my involvement with hospice, I was really trying to encourage her to start hospice treatment earlier. But there were a couple of barriers to that. She did not have a 6-month life expectancy prognosis from her oncologist, and she didn't want to give up curative treatment. As her husband and as her caregiver at home, I had to honor those wishes. But what eventually happened was that her condition became so severe, and I needed help, that she agreed at first to try palliative care at home. Fortunately, our local hospice provider, Hospice in Northwest Ohio, we were living in the Toledo area at the time, was one of the early adopters of home-based palliative care. So a nurse would come out, a social worker, and they really did help Paula a lot with keeping some of the pain and symptoms under control. She still kept declining, however, and it got to a point where, not to get too graphic, but lymphoma is very liquidy and it spreads through the body. It got into her spine, it cracked a couple of her vertebrae, and it made her mobility really limited. She really couldn't live the life that she wanted to anymore, and just her condition, she wasn't supposed to get out of bed unless I clamped her into what looked like a plastic turtle shell, tightening it as hard as I could just to protect her spinal cord. So there are a lot of other factors like that that just made her mobility and her quality of life just continually decline. However, I know a lot of caregivers can relate to this. I experienced everything that you read about in the literature. I love the term that I've seen called presenteeism, because I was still going to the office every day. I was physically there. It wasn't absenteeism, but my mind was everywhere but work. I was trying to do a full-time job. I remember sitting next to Paula in the chemo treatment center. She's getting chemo. She was actually knocked out by the Benadryl, and I was able to write like a client's entire website sitting with Paula in chemo. Other times, just the demands of caregiving took me away mentally from my job every day. I had a very generous and gracious employer. She loved Paula, she loved me, so she was very understanding, but I always felt like I was cheating my employer in a way because I just was not able to perform at the level I normally do. A lot of caregivers do experience this, but I had to make a lot of phone calls during the day. In Ohio, at least, the laws were that you couldn't just get a prescription for an opioid pain medicine and take it to the pharmacy. I would have to go physically get it, physically take it to a pharmacist. If they couldn't fill it right away, I had to wait a while or leave and come back. Just a lot of disruptions, and obviously it's a labor of love, but it was just demanding on time and energy. In addition to that, just the act of caregiving is mentally and physically exhausting. It is a labor of love, but just what your body and your mind go through in trying to care for your loved one takes everything you have out of you. Paula was so uncomfortable toward the end that we really weren't even able to sleep in the same bed, and she didn't want to disturb me. So I would sleep in the bedroom directly across the hall. Both doors were open. I had line of sight to her. And I would sleep with one eye open and one ear open just to see if she needed to get out of bed because she couldn't by herself at the end. It was that situation that I practically pleaded with her to let us sign her on for hospice care, if not for herself, then for the benefit of me. And I felt selfish doing that, to be honest, but also for her friends that were helping take care of her too. And she really did agree to do that. This is the part where it sounds almost melodramatic, but it's 100% true. A hospice nurse from Hospice Northwest Ohio was in our home, explained everything one last time to Paula. We'd been through the process with them. Paula signed the documents. She was officially a hospice patient now. The nurse left, and I really don't think it was even 20 minutes after that nurse left that Paula told me she was in extreme pain, and she just was beside herself. I'd never seen her act like that before. She was really tough, and she'd been through a lot of painful things, but she was practically climbing the walls. And I called 911. Ambulance came and took her straight to an ER. We found out that she had a pulmonary embolism. And they gave her medicines, and in the ER, she gained consciousness only long enough, and I was right by the bedside, but it was reassuring, even though she had signed the papers and even though I had medical power of attorney, the ER doc, who had great bedside manner, I saw Paula's light come back in her eyes and her eyes focus one last time. And the doctor was able to ask her, I see that you have agreed to be on hospice. Do you still abide by that? And Paula was actually able to say yes or nod her head, give an affirmative answer twice. And I was there, her best friend that was helping take care of her was there, her stepson was there. And it was reassuring for all of us to see Paula come back into her own eyes and give that permission.
Tell me about Paula's move from the hospital to the hospice home.
We went to a beautiful inpatient facility. And here's the other part where if things could have been better, I would have changed it if I could. As much as I've been a really strong advocate for early enrollment in hospice and getting all the benefit you can, Paula was only on hospice care 36 hours before she died. And everyone told me that was the situation. And thankfully, we did have those 36 hours for family. A lot of her family was in the Toledo area. My son came up from Florida, and others came from, rather far away. But those 36 hours gave time to gather in a very beautiful environment, very peaceful, and be able to say goodbye. One of my regrets, and it's not for myself, but Paula was never really ever to say goodbye back because she was still unconscious. And she really never gained that lucidity that I saw for 15 seconds in the ER. It just so happened that everyone else had left the room. And you hear these stories a lot, that people sometimes wait for other people to die or other people to leave or to be totally alone before they let go. I was in the room all by myself with Paula, watching her breathe more slowly and more slowly. And I was holding her hand, and I knew she could hear me, and I just told her it was okay to go. And she did. One amazing thing that happened was there was right next to her room a family waiting area that looked like a big living room with a kitchen and everything. My son and stepson were both in there, and Paula's room and that family room both looked out through a window on this really beautiful courtyard. And right after I knew that Paula took her last breath, my son and stepson came flying around the corner into the doorway. I mean, it was like 15 seconds later, and their eyes were as big as saucers. And they said, "Did she just die?" And I said, "Yeah." And they said, "Well, we were looking out the window, and this was a perfectly calm, cloudless, beautiful sunny day. But this courtyard had a gate. And they both happened to be looking out the window, and that gate, unattended, flew open and slammed back shut. There's no earthly explanation for it. But Paula always was a flamboyant person, and I think that was her exit to show her son and stepson that she was leaving this world to go into other places.
She was less than subtle.
Yes, no one would have ever accused Paula of being subtle, for sure.
That's a powerful story. Stan, how did you feel after Paula passed?
When Paula died, there was a sense of relief. And there was the relief that she was released from the pain and the suffering. But I don't think I'm the only caregiver, if we're really being honest with ourselves, to say I felt a sense of relief for me. Because of that treadmill that I was talking about being on and really having to just constantly be on, and even overnight, keeping one eye open and one ear open. And when you realize you're feeling that way, then that makes you feel guilty and selfish.
Yeah.
And it's not like you want your wife to pass away, but because of the circumstances, you do have this sense of relief, not only for her, but for yourself. So those were a lot of the emotions and the realities that I found myself dealing with.
So at one point you sent me a picture of her playing the drums.
Yeah.
World-class drummer?
No. That was the other thing. Even though this was, I think, during her remission, and Paula was only 51 when she died. But she was in her late 40s, and she decided, I play guitar, she decided she wanted to be my drummer. And she went and bought this really nice, red pearl drum kit. It was in our house, and she took lessons, and she really never got very good, but God bless her. God bless her for trying. I mean, she gave it her best, but that was it. She was always moving forward, never moving backwards. And that was an inspiration to me. We're talking about my transition after she died. There were great moments of grief and profound feelings of sadness and loss, but I kept moving forward too. And I think there are a lot of people that may look at their marriages and the struggles that happen with illness and have a lot of regrets. I'm very fortunate to say that I don't. Paula and I lived a very full life together. I wish things had turned out differently and her illness wasn't so agonizing for her, but wow, did she make the best of the situation and rode that wave to the very end. And that has been always a major inspiration for me as I started to put the pieces together and figure out what to do next. And that was just live each day, each moment to its fullest, because that's really what she did.
If you could share one thing, having been through the experience of being the caregiver and then being the bereaved, if you will, if you wanted to share with healthcare professionals, be they hands-on providers or leadership and administrators. Any advice that you would give our healthcare community on how to create a better experience, a different experience?
Our whole business talks a lot about patient-centered care and family-centered care. And a lot of providers do a good job, but it's interesting to me because a lot of times we try to define the patient experience, but it's really not from the patient and family perspective. It really is, what can we do clinically to really help you out? And even our language, we admit you to our program sort of thinking. I really wish that providers of any part of the system would start much more by letting the patients and families talk to them with very open-ended questions and genuinely listen to what they have to say. Some of the physicians that I've met in my career that have the best practices for that's their whole approach. And many of them are part of medical centers. They see that the way patients and families are communicated with, and they admit that these are their peers, and the peers don't even recognize that it's a problem. But again, it's this medical team coming in and saying, here's the situation, what do you want to do? And the family's dumbstruck. They don't know. The best physicians I've seen start the whole conversation by flipping that on its ear and saying, I have your mom's medical records. I see her charts. I was actually part of the team that cared for her, so I know her medical treatment. But I really don't know her as a person. What was she like? You started this conversation with me, asking me what Paula was like, what she liked to do before we got into the details of her illness. And to me, that's a perfect model, because once people start talking about their mother or their spouse as a person or their own experience, that helps unveil very organically what their wishes and goals are. And when you ask point blank, if your mom, we don't know how long she has to live, but what do you think she would love to do with the rest of her life? Mm-hmm. And again, having the patient and family say, well, this is what we would really like to see happen. Many, many, many times, they are describing the exact scenario that hospice and palliative care afford to that patient and family. They're scared of the H word. Right. They don't know what palliative care is, but they can describe it when you ask them to explain it from their own perspective in their own language. A lot of times when you have a caregiver, a doctor's appointment, let's say, or a professional caregiver comes into your home, they have a task to do. They have clinical protocols to meet. They have compliance issues to meet. I get all that. But please, can we first talk about, if we're going to say it's the patient's perspective, the patient experience, can it start from the patient's real perspective and ask them what it is, instead of telling you all the ways I can help you before I know your wants and needs and goals and wishes.
Stan, thank you for sharing your story with us. Thank you also for sharing Paula's story, and appreciate the gift of yourself.
Thank you. It was really my pleasure. I appreciate the opportunity. I've told Paula's story quite a bit because I know that she would want to educate others through her own experience, and this has been a great opportunity to do that. Thank you both.
So I have had 2 double lung transplants because I was born with a genetic illness called cystic fibrosis, and both parents have to be carriers. 1 in 4 chance of having it. I am the 4th out of 4 kids, so I'm the perfect statistic. So I have lived with this illness since I was born. It's something that causes a lot of lung infections and digestive issues. For me, it was the lung issues that were the most troublesome, in that they caused me to have lots and lots of hospital stays from the time that I was pretty young all the way up until the time I was in college, where my lung function was getting lower and lower, and I was having more and more difficulty needing more IV antibiotics. I was actually doing IV antibiotics most of the time while I was in college, and at some point it just became obvious that I wasn't going to be able to sustain that way of life. And so unfortunately I was put on a list for a double lung transplant when I was in my early 20s. I received my first double lung transplant when I was 26. That lasted for about 4 years, but unfortunately my lungs went into rejection. And so luckily for me, I was given a second double lung transplant, which at the time was sort of a rare opportunity, and certainly higher risk. So I'm extremely lucky to be sitting here now, about 15 years after that second double lung transplant.
Wow.
Yeah, so 20 years total life post lung transplant as I sit here today.
And yet your journey still continues.
Yes.
So what's going on these days?
Well, one of the things that often happens with a lung transplant is that because of the fact that the medications we have to be on for immunosuppression are toxic to the kidneys, many of us end up with kidney problems, and I now have gone into complete kidney failure. So you see my little bandage up here. This is my port for dialysis. So I'm now on dialysis and hoping maybe to get a kidney transplant in the near future. You know, one of the crazy things about being a chronically ill patient is that it's really I want to say easy to have this dialogue inside of yourself about whether or not you're sick enough for a lot of things. Am I sick enough to drop out of college? Am I sick enough to say that I need to go on disability? Am I sick enough to say that I need to go into the hospital in the middle of a COVID-19 crisis? All of those kinds of conversations are things that I think a lot of chronically ill folks grapple with. My personal opinion is that when you're female, that's even more so, because there's this sort of sense of not wanting to be a burden to people that gets layered on top of the intellectual conversation. So I did grapple with that. I didn't want to burden the teams who were working with COVID-19 patients, or my team, specifically the lung transplant team, who I assumed would be called upon because they're pulmonary docs. So that was part of the quandary that I had. But again, I'm really glad that I did go in, obviously, because I was a lot sicker than anybody imagined from what I was telling them. And again, I was pretty close to the end there. So they had to begin emergency dialysis, and it was probably one of the rougher weeks of my life, which is saying a lot given what I've been through.
You have a high threshold.
Yeah, I have a high threshold for pain, I think, and for suffering, and it was a lot of suffering. But I think it was an interesting time to be going through that suffering and to be looking at down, once again, the barrel of end of life, because I was alone. And in the sense that in the COVID-19 early days, there were no visitors allowed at all. And so while my friends and family were happy to call me, I actually didn't really want to talk because I felt so bad. So I was really alone, other than the nurses and the doctors who would come in and check on me. But when it comes to facing end of life, those are not necessarily the folks that you would talk to about what you're thinking and feeling. And when I would try to express it, like a couple of times I would say, well, you know, because I have a tendency to sort of joke about things like that. So I would say something sort of silly like, well, you know, I'm half one foot in the grave kind of thing. And everybody would go, that's not true. That is not true. And that doesn't allow me to then have a conversation about the fact that I really do believe that I have one foot in the grave. So that denial kind of that we have to try to, in a way, to be positive for our patients really cuts off dialogue.
Doesn't validate.
It doesn't validate, and it certainly doesn't make me feel welcome to share with you the fact that I really do feel like this could be the end for me. So there were a lot of moments and nights where I was alone with those feelings and those thoughts. And I guess the surprise for me was that that was really, really okay. What I've learned through this process and these 46 years of looking at this as an individual is that at the end of our days, no matter what that happens to be, whether that's from cancer or a car accident or kidney failure, you are going to be essentially alone because you're not going to be able to communicate everything that you're thinking and feeling, no matter who's sitting next to you. And the only person that you can really rely on to be there, to comfort you, to love you, to tell you all the things that you need to hear in that moment is you. And that is a beautiful aloneness. And that is an aloneness that must be cultivated ahead of time.
Given that you're relatively young, do you think that medical professionals did not really feel comfortable exploring all of the options about your care?
There's a lot of assumptions made about what people want in terms of, this idea that people want to live no matter what. And I don't know that people are really given the option to really think that through.
You actually have a choice.
Right.
Just like you got to make a choice about, and you were grappling with the choice about whether or not you even want a dialysis if the day ever came.
Yes. Yes, I mean, that's a great example. This idea of shared decision-making that we talk about in the world of patient experience isn't always as transparent as it could be. So, for example, when my kidney started to fail, I was given two options, transplant and dialysis, but they left out the third option, which is death. And that's a valid option. And I couldn't decide if I wanted transplant and or dialysis without deciding first if I wanted death. Because if I wanted death, then I don't really need to explore these other options, right? And I'm young, but I've been through a lot. My body's been through a lot. And to say that I should go through more really invasive treatments is not fair, I don't think, to me. Mm-hmm. So I had to really allow myself, and once again, I was alone in doing so because nobody wanted to have that conversation with me, but I had to allow myself to go through that process of saying, do I want to live or do I want to die? And ultimately, I chose live, but with the caveat that any moment I can choose differently. I don't have to complete any of these journeys. I can go off of dialysis whenever I want to. I can say no to the transplant if that becomes something that I no longer want to do. None of these things are, a contract.
Why do you think we have such difficulty allowing people to contemplate death as an option?
Well, somehow we feel as though it's a failure, that we're quitters.
We don't do this, you'll die.
Yeah, that's true.
In reality, we all will.
Yeah, we all are going to, and there's more peaceful ways of going, and there's more violent ways of going. And I think one of the things about medicine that we don't talk about is the violence. It's a violent thing that we do to our bodies a lot of times. I mean, getting a lung transplant, think about that. You're ripping out my lungs and you're putting in new lungs. I mean, that's pretty violent. If an animal attack did that to me, you would feel really sorry for me, right? But because it's done as a medical procedure, as a surgery, then somehow it feels safe and okay. But our body experiences that trauma, whether we call it medicine or not. And so we have to recognize that each one of those traumas is a big deal for the psyche and for the body. And we have to allow people to make those decisions about what level of violence they're willing to go through.
So what does that feel like when you're in the zone as being a patient, when you were in the hospital more recently and you weren't as strong externally and you were hearing things and seeing things but not able to participate? What do you wish healthcare professionals knew or did differently during that time?
I was honestly sort of surprised. This last hospital admission, I went from being a person, so because of my kidney disease, when I got to the hospital, I could not make sentences anymore. That's how sick I was. My mouth worked, but my tongue didn't. And I couldn't make sentences. My brain was so foggy, I couldn't find any words. And I also had these really strange sort of spasms in my limbs that were really upsetting for me. When I was in that state, where I was just mostly eyes closed, just trying to get through that moment, people were doing weird things, like slamming my gurney into the wall, slamming my chair into the wall, moving me as if I were this object. And then as soon as I got my speech back and my eyes were open again, suddenly I wasn't getting slammed into walls anymore. And I hate to say that out loud, because I wish that weren't true. But I think it's an unconscious thing. I don't care about this person. I think it's just a not seeing that person.
Lack of connection.
The same way that you see someone who you can relate to. And so I guess I would just go back to what I said a minute ago, which is the internal body isn't being reflected by the external impression that you're getting from someone. And just because their eyes are closed and just because they're not communicating with you doesn't mean that they don't feel pain, doesn't mean that they don't feel humiliation. That was humiliating for me. To feel like I was just this kind of piece of meat that was getting thrown against the wall, that was more upsetting to me than maybe anything. So I don't know how you keep that in the front of your mind as a person who works with patients every day.
So Tiffany, I'm going to cheat a little bit on our interview right now. We've been really talking about your personal perspectives, but I'm actually going to ask you for your professional one for a moment. Our industry's having a lot of discussion about health equity, particularly around people of color. Thoughts on this?
Right now, the conversation is about systemic racism in healthcare. Systemic racism in healthcare came about because of the way we built our systems. The system is actually working the way that it was built to work. So the fact that we have these outcomes with COVID-19, that we can clearly see that our people of color are not being served through our healthcare systems, is actually the system working the way that it was built to work. So how do we break that system down and redesign it with those who we serve so that they can then help us understand what the needs are, what the changes need to be, and how we can move forward from here and actually accomplish what we want to accomplish as a community. So listening literally, listening as an individual, and listening as an organization.
So the near-death experiences that you had in your 20s versus the one that you had in your 40s, were they different at all as far as sort of your growth and maturity? Do you have different reflections of how that's changed your life moving forward?
Every time I've come close to the end of life, there's this great sense of everything's happening for a reason, which is so hokey. But I mean that very specifically. So, example, right before I went in the hospital was when COVID-19 was really hitting. And what I saw was perfection, order, purpose. This is not happening to us. This is not a punishment. This is on purpose for a reason, at the right time and the right place, because there's something that we have to do differently, or because we have to learn something. And I see that in my personal life as well. So everything that is painful, everything that is undesirable lines up as a beautiful puzzle with complete order and purpose that is meant for me to do the puzzle, learn the lesson, grow, see the beauty of this universe, because nothing is permanent. Nothing can really hurt me. If death is the worst thing that can happen to me, then that's, as long as I'm okay with dying, then really it's all about just soaking it up and figuring it out and learning what this puzzle is trying to tell me. And for me, end of life, again, I've never gotten to the point where I was, taking my last breath, luckily for me. But I do feel like I've walked with one foot here and one foot on the other side. And that energy is not mine. That energy of seeing the perfection, seeing the puzzle pieces, that's not me. That's not coming from me. I know that is an energy that is coming from somewhere else. And it gives me a lot of perspective.
If there's anything that you could change about your experience, what would it be?
I think that's one thing I'd love to change in healthcare, if I could wave a magic wand, is this concept that when the body is weak, the person is weak. I think it's the opposite. I have seen my greatest strengths in my moments of greatest physical weakness. And to have people come in and judge me as weak in those moments feels very unaligned. That's not the right word. Discordant with my reality. My reality is I'm a badass, curled up in a ball, doing everything I can to hang on. And someone comes in and talks to me like I'm a baby, or talks to me like I'm dumb. And I'm like over here killing it, over here in my greatest level of concentration, my greatest level of clarity, my greatest level of grit. And to see me as weak is wrong. It's just wrong. And I don't think that matters. I don't think that changes if you're 89 and on your deathbed and taking your last breath. I think it's the same. So that would be one thing I wish I could change.
So as we try to combine the stories of Steve and Tiffany and Stan in whatever order they mix up, and frame that in the concept of spark, service, purpose, resilience, and experience. Mm-hmm. Each one of them shared elements of how they found resilience, but also how they wanted a different experience than they actually got in some ways, or they wanted a different experience for their loved one than they got. What is your thought on that?
The thing that really struck out to me was to be heard.
Yeah.
Just please listen, hear the words, hear the intentions if I don't have the words. And the fact that everyone was feeling like, even in this country, in healthcare and beyond, that their voices are just crumbled.
I want you to know me,
Right.
not the patient, not the symptoms, not the medical record.
The medical intimacy part. That's a
you to know
scary
me.
word.
Well, it means we're going to have to get connected.
Right.
And we've always talked about professional boundaries, but then where do we connect that back to our own vulnerability and our own authenticity to show up real and then get real?
And I think some of the disconnect that we're experiencing and perhaps some of the issues that we're having with folks leaving the workplace is because we're taking some of the humanness out of our work. We're expecting people, it feels like, to be almost robotic in the nature in which we're providing the care, but still provide the care and be loving, but don't connect. And so then where do you go with all of that?
We start playing by the rules. And that's maybe not the right way. We get playing to the rules. We should all play by them, but we start playing to them as if that's the end game, as opposed to showing up with this compassion, this authenticity, this vulnerability, and creating an experience in the workplace, but also at the point of care that resonates with people, that connects with people. People who are connected and engaged don't leave their work. Patients who are connected and engaged with their providers have a great experience.
And I think to look at ourselves, of those of us who are in leadership positions, and to actually lean into that, even though it feels uncomfortable, you almost feel like you have to have a wall around you when you're a leader sometimes, but to actually lean into that connectedness and actually show that with the staff that you work with. And so that way they feel comfortable to do that with the patients under their care.
Am I vulnerable as a leader? Am I authentic as a leader? And am I approachable in that authenticity? Because that's an uncomfortable space, and somebody will take advantage of it.
And can I have those courageous conversations? We can't keep losing the good people that came into this for the right reasons.
People are opting out. I don't want to play to the rules. What I want to do is deliver care. I want to connect to patients. I want to connect to the people that do the work. That is why people show up. And that's why they stay there. And the only thing worse than the opting out of our industries of healthcare is the presenteeism, where I'm going to show up, but I'm just mailing it in. I'm not really here. Did my whole person show up? And have we created a work culture where my whole person can show up and I feel like that's safe?
And do they have an outlet to go to when they are having those moments of feeling that connectedness and losing a patient or having a very difficult conversation, and then feeling like there's a safety net to go to kind of fill yourself back up and to be able to take that step into that next room?
Yeah, I mean, what do I do when it's a lousy day? What do I do when I probably shouldn't be at work? Do we make it okay for folks to not be okay and give them that outlet so that they're able to really show up in the best way possible? We're asking a lot of people. And are we giving them the best of ourselves to create an environment where that's really fostered and nurtured? We don't talk about nurturing very much.
One of the things that really struck me from the conversation was the word burden.
Yeah. Each person brought it up or they used a different word for it, but they all talked about burden today.
Burden as myself needing care. I don't want to be a burden on the system. I don't want to be a burden on the system right now when the system is already so complicated. No. I don't want to be a burden on you, my husband, because this is just too much for you.
Right.
And
as a spouse, as a friend.
I think we need to understand when people are facing some of these life-limiting and chronic illnesses that, as human beings, we don't want a burden, right? We want to survive, we want to thrive, we want to be the best we can be, we want to be able to handle everything that we have around us and that we're supposed to be responsible for. And the minute that shifts and we need that support, people are kind of walking in with that feeling of I'm already just too much.
So how do we make a space for that as leaders? Find our own resilience, show up vulnerable, show up compassionate, have the courage to be authentic and lead in that way. We're asking a lot of ourselves, but if we don't do it, we're going to continue to have people leave. And I think we're not going to be able to create the experience for people that they want and that I want. I want to work in an environment like that.
I don't think the stories of Tiffany, the patient, of Stan, the one left behind, or of Steve, the current caregiver, are all too different than those that are in those current roles that we may know.
My guess is there are folks going to watch this. These stories resonate with them. They may personally identify. They know a Stan or a Steve. They know a Tiffany somewhere. This is their story or the story of someone they've treated. These are not concepts. These are people.
And what do we do to make it okay for the people like Tiffany to feel like they have somebody to turn to, the patient, when you are facing that life-limiting illness and you want to look down all the different possibilities and have somebody there that can be a sounding board if you're looking at no treatment as an option. Doesn't matter that I might be 40 some odd years old as she is. I need to look at that option. How do we make that okay? How do we become comfortable with that?
She needed some fearlessness. She needed a provider to overcome the fear of talking about death. And it's scary. It's hard listening to her talk about it.
Mm-hmm.
But we need to be fearless in our vulnerability with our patients, fearless in that authenticity.
And not put what our desires and wishes are for maybe our own selves, if we were in the situation, onto somebody else. And that's hard to do too. If it's hard to remove your lens.
Well, I'm glad that they shared those stories with us.
Me too.
I'll remember them.